Hi everyone. In this video, we'll be talking something about the story of anesthesia, how our specialty of anesthesia evolved. But before I start this video, I would like to say that yes, I know that history is something that some people don't really want to read about, but you'll see that it is always the first chapter in books. And after all these years, I have realized it is always good and interesting to know something about how our field of anesthesia started. So, the word narcotic means drugs that produce analgesia. Analgesia is pain relief. You'll be hearing this word very often during your practice. And the word narcosis is state of stupor or sleep. It is the state in which a person goes when we give anesthesia to that person. The term anesthesia which we use every day, was used first for the first time in the 1st century AD to describe narcotic-like effects, that is, the analgesic effects of the plant mandragora. Then in 1846, this scientist Oliver Wendell Holmes was the first to propose the use of this term to denote state that incorporates amnesia. Amnesia is forgetfulness, that you don't remember what happened during your surgery. You don't remember the anxiety, the pain. So it helps. It is very important part of anesthesia because of this, you don't go through post-traumatic stress disorder. Some people who have awareness may experience that. So, and then analgesia, as we have already discussed, pain relief and narcosis. So these three things are important for painless surgery to be possible. This was realized in 1846. Then in the second decade of 20th century, the term anesthesiology, our field, was proposed to denote practice of study of anesthesia. So it was around mid-19th century that specialty of anesthesia began. Ancient people before that used to use like opium poppy. It contained morphine. That time they didn't know. And the coca leaves. Surgeons used to chew the coca leaves and spit it on the wounds for local anesthesia. Mandrake roots were used for narcotic effects. Alcohol was used to produce that transient state so that surgery could be possible. And phlebotomy, that the patients were bled to the point of unconsciousness. So see, it was so risky that time. This was all done to allow surgeons to operate. For regional anesthesia, that time spinal and epidural were not invented. So nerve ischemia was given by compression of the nerve trunks and cryoanalgesia by application of cold. This was all done because hypodermic needle was not invented. It was invented in 1855. So no IV anesthesia was possible before that. So if we see the history of anesthesia, first mode of anesthesia was inhalational, followed by local or regional, and followed by intravenous. So first we'll study something about inhalational anesthesia. So in 1540, way back in 1540, diethyl ether was prepared by Valerius Cordus by chemical reaction between ethyl alcohol, which was very much prevalent, and sulfuric acid. But it was not used for giving anesthesia. It was only used by ether florix. So first compound that was made for inhalational anesthesia was nitrous oxide, and surprisingly even today we are using it. So it was the first thing to be discovered, and even today we are using it. In 1772, Joseph Priestley was the scientist who exposed brass to nitric acid, HNO3, and NO, nitrous air, was produced. Then this NO was exposed to iron fillings and mercury, and dephlogisticated nitrous air was produced. This dephlogisticated nitrous air is now called nitrous oxide, which we use in our operation theaters. It means that it aids in combustion. But it does not support life. We know today also that if we give 100% nitrous oxide, then the patient can survive. So there was no practical use at that time because it was not used with oxygen. In 1800, after that, Humphrey Davy was a scientist who constructed an airtight room with nitrous oxide. And he discovered that nitrous oxide caused feelings of exhilaration, euphoria, and analgesia. But still, for 50 years around, its analgesic properties were ignored and it was not used. So then in 1844, Samuel A. Cooley, under the influence of nitrous oxide, actually he was in an exhibit. This exhibit was designed by scientist Colton. he wanted to demonstrate effect of nitrous oxide. And during that time, the Samuel A. Cooley suffered a leg injury. And in that leg injury, he suffered no pain. He experienced no pain. So that's how they got to know about the analgesic effects of nitrous oxide. So next day, what happened was that Horace Wells, he was a dentist. He called Cooley to his office, and there he asked him to give him nitrous oxide and for extraction of his own tooth. And he experienced no pain during that time. And so they all discovered the analgesic properties of nitrous oxide. Even after all this, nitrous oxide was not popular because of its low potency. We know that nitrous oxide is required in very high amount. As high as 80% nitrous oxide produced only analgesia, that is pain relief, but not anesthesia. So no other component of anesthesia was there. It also caused asphyxia because it was not used with oxygen that time. It was used in 1868 with oxygen. After nitrous oxide, diethyl ether. As I have already told that in 1540 it was used by ether frolics, but in 1846, 16th October 1846, it is the most important part in the history of anesthesia. And actually, this question was asked in my exam also. So, W.T.G. Morton, by the advice from chemistry professor Charles A. Jackson, William Thomas Green Morton, he first time publicly demonstrated the use of ether to produce anesthesia in patient named Edward Gilbert Abbott for excision of neck mass by Dean of American Surgery. The surgeon was John C. Warren. As you can see in this picture, this is the same picture which was taken during that demonstration. So it was demonstrated in Boston, Massachusetts General Hospital, which is popularly known as the Ether Dome because it was public demonstration of ether anesthesia. So every year on 16th October, that is why we celebrate World Anesthesia Day. Then let's talk about chloroform. Chloroform was prepared by Liebig, Guthrie, and Sobersian in 1831, but it was first used clinically, first used in 1847 and introduced into clinical practice by Scotland obstetrician Sir James Y. Simpson to relieve labor pain. Now, chloroform was invented because ether had certain disadvantages. It was flammable, it had prolonged induction of anesthesia, there was delayed emergence, and there was increased nausea and vomiting. But chloroform also caused certain disadvantages that were cardiac arrhythmia, respiratory depression, hepatotoxicity, and so it was also abandoned. But chloroform still is famous because John Snow, you must have heard about John Snow before also. So he popularized this chloroform by giving chloroform to Queen Victoria of England for delivery of her 2 children. Ether remained standard inhalational until 1960s. Then cyclopropane was also introduced, but they both were combustible. Therefore, they were replaced by non-flammable potent fluorinated hydrocarbons. So these are used even today. As you will go to your operation theaters, you will see that on the anesthesia machines, there are vaporizers which contains halothane, isoflurane, desflurane, sevoflurane. So out of all these, halothane was the first to be invented. It was released in 1956. Then methoxyflurane and fluorine. Isoflurane came in 1981. These are recent ones. Then the desflurane in 1992, it has more rapid uptake and elimination. Now desflurane is very famous, but these days there is a concern that it is causing a lot of atmospheric pollution, and actually in Scotland it has been banned also. So let's see what happens further. Then sevoflurane is the recent most. Its release was delayed because of potential toxicity. It produces compound A. This we'll be learning in detail in the inhalational anesthetic topic. After inhalational anesthesia, we'll talk something about local anesthetics. So first local anesthetic to be developed was cocaine. As we have already discussed that earlier, surgeons used to chew coca leaves to spit on the operative wounds for local anesthesia. So it was isolated in 1856, but it was used clinically in 1884 by Carl Kohler. This was the ophthalmologist. He demonstrated anesthesia of corneal surface of eye. And in the same year, William Halsted used it for intradermal infiltration and nerve blocks. So cocaine was the first local anesthetic used by Carl Kohler. Then the first spinal anesthesia, which we give now also, it was used by August Bayer. August Bayer was a scientist who discovered first successful spinal anesthesia in 1898. Then the first caudal was introduced in 1901 in the 20th century, just the beginning of the 20th century. Caudal was introduced for surgical anesthesia. Procaine was also synthesized, and within a year, it was used by Heinrich Braun. He was first to add epinephrine to local anesthesia. You know what? If we add epinephrine to any local anesthesia, it prolongs the duration of action. You will be using it very often, and then you'll realize that it dates back to 1904 that they are using it, and we are using it still. And August Bayer, as I have said, that he was the first one for spinal anesthesia. He also invented this Bayer's block in 1908, 10 years later. He was first to describe intravenous regional anesthesia, IVRA. So two tunicae are inflated and local anesthesia is given in the vein. It is a very unique technique, and we'll be learning about this in detail later on. It only anesthetizes that particular arm. Later on, percutaneous block of brachial plexus was described, lumbar and thoracic epidural. See, first of all, after caudal came lumbar and thoracic epidural. It was described in 1921, but the LOR technique we'll be reading in epidural anesthesia, loss of resistance technique. This was discovered by Achille F. Dogloity in 1931. It is that much old. And in mid 20th century, epidural method for obstetric pain relief was introduced. We'll be learning about these also in very much detail. And now the newer local anesthetics that we use. We frequently use lidocaine and bupivacaine. So lidocaine was invented during 1947, independence time. And after that, in 1963, bupivacaine came. Then the recent ones, but bupivacaine is cardiotoxic. So recent ones, ropivacaine and levobupivacaine, which are nowadays are used a lot, are less cardiotoxic, and they were invented. After local anesthetics, we come to intravenous anesthetics. Now, the hypodermic needles, as I have already said, were discovered in 1855. So, tracheal intubation, you'll be doing this daily in your operation theaters. But the first airway devices were used by ENT surgeons and not anesthetists. We were not there at all. So it was used by ENT surgeons. Jackson laryngoscope. They used it to remove foreign body from airway or for resuscitation from drowning. Then Goodall, Waters, and McIntosh were the scientists who pointed out the advantage of tracheal tube, the endotracheal tube, which you use daily. It was pointed out that the endotracheal tube can be used to protect the airway, to give continuous positive airway pressure, and for convenient access in head and neck surgeries. The laryngeal mask airway, which also you will be using daily, was invented much later, like in 1983, for selected elective surgical procedures and alternative and difficult airway management. You'll be using it daily. So you'll get to know about this in detail later on. The induction agents. First, we come to induction agents, then neuromuscular blockers and opioids. So every day in all the patients, while we give general anesthesia, we'll be using propofol, thiopentone, ketamine, etomidate. These 4 induction agents we use. And so out of all these, thiopentone was the one which was discovered, which was invented the first. It was first used clinically by Waters and Lund in 1934. The second one was ketamine. Ketamine was released in 1970. Ketamine in 1970. It was released and used first clinically by Corson and Domino. Then etomidate after that was released in 1972, 2 years later. And propofol, which most of you will be using daily, is of the shortest duration, and it came in 1986. So propofol is the recent most. And now we come to neuromuscular blocking drugs. So curare was introduced in 1942 by the name of intocostrin. It was used for tracheal intubation and muscle relaxation to relax the abdominal muscles. The advantage was that the operations could be done without giving much of the inhalational anesthetic, because when we give a lot of inhalational anesthetic, it may cause CVS and CNS depression and respiratory depression. So with the use of neuromuscular blocking agent, there was avoidance of prolonged emergence. Succinylcholine, which we use now also, was introduced in 1949 and it was released in 1951. It is standard for rapid sequence intubation. This you will be learning later. Then came galamine, decamethonium, metocurine, but these all had side effects. The newer ones, which we use today also in our operation theaters, are vicuronium, atracurium, cisatracurium, rocuronium. Then we come to opioids. In 1805, morphine was discovered by Sir Turner, but a high amount of opioids caused respiratory depression. So concept of balanced anesthesia came. It was a concept which was introduced by Lundy in 1926. He used different agents in small amounts so that everyone caused some effect, but there is no side effect. So thiopental was used as induction agent, nitrous oxide for amnesia, opioid for analgesia, and curare for muscle relaxation. Then came the short-acting opioids in 1960s, so that there is no need for post-operative ventilation, which we use now also, like fentanyl, sufentanil, remifentanil. Subarachnoid opioids were used in 1979. Besides these, there are some important discoveries during the evolution of our specialty. First is John Snow. John Snow is the father of anesthesia, as I have told before also in the chloroform section. He is the pioneer in epidemiology. You people must have heard about him during your PSM classes. He stopped the cholera pandemic. He introduced the first book on general anesthesia in 1847 and the second book on chloroform. Then there is this Joseph T. Clover. He was the protective kind of an anesthetist. He started he started monitoring pulse during anesthesia. He used jaw thrust maneuver. He insisted resuscitative equipment like ambu bag to be always available during anesthesia, and he was the first one to use cricoid cannula to save patient with oral tumor who developed complete obstruction. Then there is this Sir Frederick Hewitt who introduced oral airway, and he introduced first textbook of anesthesia. Goodall, you will be learning about Goodall's airway. He was first to describe stages of general anesthesia. This also we'll be learning later in our subsequent lectures. He advocated cuffed tracheal tubes and he introduced artificial ventilation during ether anesthesia. Besides all this, there are some equipments which you'll be using daily in your operation theaters. Rivarosoi method for BP measurement. It was introduced in 1896. The anesthesia machines evolved from simple ether bottles and tubes to portable gas tanks, large standalone units, and now which we use as an anesthesia workstation, which has flow meters, respirometers, and ventilators attached. This was all evolved during the second half of the 20th century. Then there is blood class analyzer in the anesthesia machines. And then there is pulse oximeter, and in 1974, ET gas analyzer end tidal. It was introduced in 1960s. It measures end tidal carbon dioxide and MAC. And then there is this sophisticated transesophageal echo. It was introduced in 1982, and it is used today also. So that's all about the history of anesthesia. So we have seen how our specialty of anesthesia began from the mid-19th century. Earlier, we were using only leaves and alcohol and phlebotomies, and which were very risky. Then, first of all, inhalation anesthesia came into existence. We started using nitrous oxide. Then there was a development of diethyl ether, chloroform, and then the modern fluorinated hydrocarbons like halothane, isoflurane, sevoflurane. And then we have read about local anesthesia. Cocaine was the first local anesthetic to be discovered. And then the spinal anesthesia, epidural, caudal, everything was discovered subsequently. And then we studied about intravenous anesthesia. In intravenous, we studied about induction agents and neuromuscular blockers and opioids. And we also read something about how the anesthesia machines evolved and the newer equipments which we used. So this was all about this video. Thank you.